Let's go over cardiac and cardiovascular disease. Remember our learning objectives in an organized fashion. We want to ID and treat any life threats. In an organized fashion, obtain an accurate history, perform an examination. We want to be able to organize these into formulating a diagnosis and a list of differential diagnoses as we go on, and maybe refine this differential diagnosis list. All right, so as we look at the cardiac anatomy, we want to remember that there are organs that lie within the thoracic cage. Usually we think about these as the pump blood in the blood vessels, and we need these to work in a fashion so that it can deliver oxygen, nutrients, and remove waste products. If not, we're outside of the homeostasis. We end up in something called lack of perfusion or hypoperfusion, and we end up with a patient that's in shock. This could be caused by any number of disease processes. Some of this could be due to obstructive, hemorrhagic, or hypovolemic, and we could have distributive type shock that's going on. Remember that when we look at somebody that's complaining of chest pain, this could be multiple reasons and etiologies for the chest pain. It could be musculoskeletal and somatic. It could be visceral, maybe something in the epigastric region. It could also be the cardiac muscle, and we would also have some referred symptoms as they kind of branch out. Remember that also cardiac chest pain has to be differentiated between GI, respiratory, musculoskeletal, and the like. So here we go. Let's go over our first case. We're dispatched to a patient at a nursing home that's having some chest pain and trouble breathing. So now we wonder whether or not what came first. And we're going to a nursing home. We probably want to get more information as we go along, but we start to figure out what's going on. Here's our AMLS pathway. As we go through, we want to keep it in an organized fashion. What do we think about as we get there? We decide that the scene is safe. It's an entry into this care facility. Usually these healthcare providers should have information, at least paperwork, documentation. They may have seen the patient and should have got some kind of exchange in their turnarounds in the morning or in the evening, as far as an update of what's this patient's status and why they're there. So we get some of that. As we look at the patient, we want to be able to see, well, what do they look like? How are they positioned? Is there anything else that we need to be aware of? So this is assisted living skilled nursing center, and there's a few residents that live there. It's staffed 24/7, and they called us for 911. We get there, and the person is awake. His airway is open, breathing adequately. His pulse is weak and rapid. So now it doesn't really show us what we're looking at, but at least we get an idea of airway, breathing, and circulation. Does he have any life threats, and is the patient sick? Potentially the person is sick, and being sick or not sick, you'll have there's a spectrum of what people would consider. Just let's move through the case as we can. What could be causing some of these symptoms? Is it an MI? Is it these other acute things like a pulmonary embolus, as the person may be bedridden and he's in this chronic skilled nursing facility? And why is that person there? Is this because of some other type of chronic degenerative illness? Are they there to convalesce, or are they there for a reason? So as we look at our differentiation, our problem list, some puts it into the life threats that we need to really move on. Some are critical, some are non-critical. We go next into our history. We want to find out more about what's going on to refine our differential. And we use OPQRST. Again, some of us would be looking at the OPQRST. Some of us might be diving into our meds, past medical history, to give us an idea of why they're there. And some of us might be diving into our physical assessment and diagnostic tools. Here we see it's a 6 out of 10, and the person was smoking, decided to get this cough. We get into the OPQRST, we get into our sample history. It's on the left side, so it still could be cardiac. His past medical COPD happened 2 hours ago. All right, so now there was some issue about smoking vacuum cleaner and some cough that was triggered by that. Is that's what's causing it? We'll take a look a little more and we'll see the patient's vital signs. Tachycardic, SAT's not that great. End-tidal CO2 is climbing here. Respiratory rate is elevated, is afebrile. We got pursed lip breathing, so his work of breathing is up there. Scattered wheezes. So it doesn't look like we got much of a cardiac in nature, but more of another respiratory case. But let's kind of move on and see what else is going on. Now we do have some crackles, so we might think that there is a respiratory versus a cardiac component. Here are further diagnostics. We have a blood glucose level of 87 sinus tach, 12 lead EKG is unremarkable. Again, the end-tidal CO2 is kind of high up there. And they're telling us that the shark fin pattern or waveform is there. Here we see that waveform, well, not as clearly as we saw in the previous, but we are starting to develop. And what's happening here is that when they're trying to inhale and exhale, that inhalation is going up and exhalation is kind of prolonged and causing this type of steep shark fin pattern. So let's go over some of the differential diagnosis as far as what we might think is going on here. Is there an MI? Is there a possibility of that? Acute ST changes? Is there possibly pulmonary AMLS or a pneumothorax? Is there some history of heart failure going on? And an acute presentation of pulmonary edema where we have the absence of the right-sided congestion. And so right RV failure is not really present in the absence of peripheral edema. But here we can take a look and start to think, what are rule outs and how do we treat them? What are our BLS supports? What are our ALS life supports? And what would be any critical care issues or measures that we would start to think about in this type of case. Now this wasn't a clear-cut case where our 12 lead did not present to us. In fact, they basically gave us this EKG finding and then went back and told us that in our diagnostics that we see in a 12 lead EKG here, sinus tachycardia, but the 12 lead was unremarkable. No blood gases to go on. But we could think about if we were in this critical care area, that we would maybe looking at other things. Some of us are familiar with a BNP, which might tell us that there's a increased pressure in the lungs causing the fluid to build up there, and we got some congestion going on. What other enzymes might we be looking for? We might be thinking about some cardiac enzymes, and what we might be looking to see in there is the troponin elevated, CKMB elevated. And as we go back again to our differentials, and as we slowly roll these out, we kind of have to piece back and forth. What was the history of present illness? How did our patient present to us? What was our patient's past medical history, meds, allergies, the sample history, and then putting together our diagnostics, again coming to our list of differentials and how we would treat this.